Good evening, everyone, and welcome to tonight's GP Education webinar on research update in skin cancer screening. Before we begin, I'd like to acknowledge the traditional owners of the land upon which we meet, the Noongar Whadjuk people. I would also like to pay my respects to elders, both past, present, and offer my acknowledgement and respect to other Aboriginal and Torres Strait Islanders who are present with us today. Throughout the night, if you experience any IT difficulties, please feel free to contact us on the phone number provided on the screen or through the email also provided on the screen, and we'll be sure to help you out. So tonight we have Professor Scott Kitchener from Queensland, Griffith University. He will be presenting and sharing his findings from a research conducted in skin cancer screening in rural communities and what this means for general practice. Professor Scott, he's presenting remotely from Queensland, so this is a new system that we're trialling out. So if you do experience any IT difficulties, please do feel free to contact us, and I'll now hand it over to Scott, and he will start the presentation. Thank you.
Thanks very much. So I can't see anyone, but welcome for those of you that are here. Some of you may have actually heard part of this story at the Skin Cancer Congress recently, where the data was presented. I like telling the story because it's a good news story for general practice, and it really highlights the strength of general practice, and I think the model of care of primary care in identifying and managing skin cancer. I'm happy to take questions anywhere along the way. I don't know whether there's some sort of a hand signal that you can do, or perhaps you could just interrupt and hopefully I'll hear what you're saying. Is that all right, Zane?
Yeah, so for questions, sorry I didn't mention this earlier, but if you have any questions, there's a comment section for the people viewing on the sidebar, so you can just type in your questions and I'll forward them on to Scott and he can answer them for you. Thanks.
Okay, so you're going to text them to me and I'll take them when you send them. So this is actually all research that was done in general practice on the Darling Downs. And it was done primarily by students under the supervision of local general practitioners. Next slide. The bandwidth does slow down a bit, doesn't it? So this is just some background on the epidemiology. You're aware of the risk of rural people from cancer in general. There's estimated to be 9,000 additional deaths in the first 10 years of this century. That's some data from Curie and the MJA. Within that inter-regional, which is where we did this research, RA 2 and 3, some of it was in 3, has the highest incidence of the 4 commonest cancers, but you're probably all aware that the commonest cancers are actually not measured in Australia, and that's non-melanomatous skin cancer. It is estimated that the cost of managing non-melanomatous skin cancer or keratinocytic cancers is actually as high as all other cancer costs put together when you take into account the Medicare rebates as well as the ongoing care when it gets referred into hospitals. What's not up there also is that the number of deaths from non-melanomatous skin cancer is about half of all the deaths from melanomas. So it's still quite a significant number of deaths, and certainly more deaths from non-melanomatous skin cancer occur than motor vehicle accidents, for instance, in the States. So it's a significant number. I think the last count in 2016 was well over 600, I think it was about 690, mostly squamous cell carcinomas that were not managed. There's some more statistics there for you, just to put it in perspective with melanoma as well. I did try to look for what proportion of melanomas are diagnosed in situ, which obviously is an important aspect of melanoma particularly, and there are some studies that look at it in Australia. About 36% of melanomas that are diagnosed in situ. But despite all of this, in Australia, the epicentre of the epidemic of skin cancer on this planet, we still don't recommend screening, which I find really quite extraordinary. And I think it's actually more to do with the politics of medicine in Australia than it is to do with any sort of common sense. So this part of our objectives were to try and address that or look at that. Could you go to the next slide, please, Anne? So this guy's a fellow that comes to see me where I practice in Clifton. He's a horticulturalist and he doesn't like wearing his shirt. And I put him up because he's one of the reasons why we particularly started looking at this. I do teach my students and registrars the ugly duckling sign, where the pigmented skin, everything else is. It's the one that's medial to his left scapula. And if you click it again, Zana, the arrow comes up. And that's actually a melanoma that we were able to identify and manage without him leaving town. So that's one of the reasons why we do it. The other reasons to actually research this was because of the cost of basal cell and squamous cell carcinomas, but no one really knows what the epidemiology is. And in fact, when I ask students and audiences that I can see and speak to, what is the risk of farmers for skin cancer, they'll generally say, oh, well, you know, they have more of everything, more melanoma, more basal cell and more squamous cell. There's actually no evidence for that. No one's ever looked at the relative risk of farmers or, for that matter, of rural communities for skin cancer. We did actually go back and do one of those searches where you sort of look back steadily to see what's been referenced for melanoma increased risk in farmers, and it all goes back to the oldest reference we could find was to a mortality study in Kentucky that indicated that farmers possibly have an increased risk of dying of melanoma. But as you probably all know, dying of melanoma isn't necessarily related to your risk of getting melanoma, and particularly in Australia, dying of melanoma may well be related to your healthcare access as well as your risk of actually getting melanoma access for the purposes of being diagnosed and for being managed. One of the interesting pieces of research I found that was actually based in Queensland, identified after looking at the epidemiology of regional melanoma and non-melanoma skin cancer, particularly identified that outdoor work was not related to an increased risk of non-melanoma skin cancer. There are a lot of outdoor jobs in regional and rural Australia. I found that pretty interesting. Next slide, please. So here are the aims of the studies that we looked at. It was to identify the nature of skin cancers diagnosed in rural practices, because it's quite possible that that the nature of the cancers that we're seeing are actually different. The distribution, the mix of those, and stage that they're being identified at. And particularly wanted to look at whether or not there was an advantage or disadvantage to the management of skin. Sorry, I got a text from someone else that's not related. In rural communities, and you know, I worked in WA, and outside, I noticed that outside Perth and Mandurah and Bunbury, it was pretty much primary care all the way through, and that's potentially considered to be by my specialist colleagues to be a disadvantage in care, whereas my gut feeling at this time when we started this was that it actually is an advantage for rural people to have the sort of access they get to general practitioners. And then we particularly wanted to find the relative risk to farmers. Next slide, please. So this is the metropolis where I work. That's actually West Clifton, and you can see it's an agricultural community, mostly based on broadacre cropping, large silos for feed storage, and these were the methods we used. The sort of thing that you could definitely do in any general practice. And I know I've spoken to some GPs in WA about replicating this research. We did it through RACGP ethics approval. Essentially, the case identification was done by Medicare billings, and we did it for the period prior to that major change in the item numbers. But, you know, as for those of you that are practicing in general practice, you'll be aware that you can readily identify particularly melanomas and non-melanoma skin cancers by the surgical management. Obviously, we're potentially missing medical treatment of basal and squamous cell carcinomas and intraepidermal carcinomas. And we're also potentially missing in this method the number of cases that are actually referred out for definitive surgical management away from the practice. So the way we addressed that was we also looked for 30071, so biopsies that identified these. We also looked in 30202, I think it is, which is the removal of benign tumours, which is certainly in the Darling Downs was a method that a number of GPs used for the purposes of getting a rebate for a tumour that they initially excised in an excision biopsy as opposed to a punch biopsy or a shave biopsy, but then referred it off and couldn't legitimately claim the definitive surgical management. So we try to capture all of the, or as many of the non-melanomatous as well as melanoma skin cancers that were being diagnosed and managed in these 7 practices across the Downs. One of the huge advantages of doing research in general practice is that it is streets ahead of, it's a decade or more ahead, in my opinion, of Queensland health hospitals. And I imagine the same in WA with respect to electronic clinical record. And we're able to go from the billing data to the patients and then look at the reasons that the person presented, as well as look at their histology. That was all in one place, and that's a massive advantage for research. It's difficult still, I think. I don't know whether you probably do have PCS data that's surveying your electronic clinical records. I don't think that's quite evolved yet. We're actually doing some work in that space to try and get this data collated. But essentially, the patch that we use, the software patch that we use to collate the billing data to the clinical data to the histology data was the Mark 1 medical student. And, you know, they're actually really good clinical investigators when they have an understanding of what they're doing and a belief in what they're doing. And I was very fortunate to have really motivated young med students, many of whom did this as summer scholarships. Next slide. So this is another farmer who had what turned out to be a basal. And, you know, I did the right thing here and said, you know, I think this is a non-melanoma skin cancer, but you can see that it's actually blanched. So we did actually take it out here. I said to him, look, you should go up the road and go in to see the opthal, or the nearest opthal that would do this sort of work is about 200 kilometres from us. There's actually a plastics visits about 100 kilometres away, but he said, look, you know, just get on with the doc. And so if you click again, Zany, you'll see that it actually came off and came together pretty well, which allowed us to claim that as a billing, which meant that we were able to identify the billing numbers. And these were the numbers for non-melanoma skin cancers. Next slide. He still sees me, by the way, and it hasn't recurred. So just click it again. So these are the Medicare item numbers for malignant melanoma that we did, and that's actually the melanoma on that horticulturalist getting taken off. We did it with a margin that accommodated for what we thought was going to be the depth of the melanoma. And that's actually being done by a student. We try to get our students for a year, and we try to make sure they get to the point of being able to do their own excisions from go to woe. Next slide. So here's the data for basal cell carcinomas, and we compared this initially to the Q-Skin study, which is a big study done with millions and millions of dollars, lots of zeros afterwards. And it was done based out of the QIMR Centre, Queensland Institute of Medical Research in Brisbane, and essentially they're farming the registry data for their melanoma information and for their non-melanoma skin cancers. they were looking at Medicare billing that they got as population data from Medicare, and then they would follow some of them up to confirm the histology. Now, their catch rate on histology was down in the 60s, 60%. I think it was 67%. For us, the catch rate using our methodology with the Mark 1 medical student was in excess of 99.9%. We did find in the 5,000 odd skin cancers that they looked at, about one or two that had been misbilled, miscategorised for patient billing. So the point of this slide, though, is to identify that there was a statistically significant difference, thanks, Anna, between the sorts of basal cell carcinomas, the distribution of basal cell carcinomas between Queensland state data and the data on the Darling Downs. Now, the data on the Darling Downs is obviously Darling Downs data, and it's small rural communities. It doesn't include people in Toowoomba, whereas the Queensland data is really heavily dominated by the metropolitan strip from Tweed up to Noosa, and then the larger regional areas along the coast. So these are different people, and I think this is one of the big points that we were looking for, is that can you actually extrapolate that state-level data or even national-level data to your region? And very clearly, it's different on the Darling Downs. Next slide, or next click. Thanks. So this is the squamous cell carcinoma, and again, there'll be a blue circle turn up that demonstrates that there is a difference, a statistically significant difference between the distribution in the head and neck of squamous cell carcinomas between the state data and Darling Downs. Now, I mean, I'm not sure how to explain this. I suspect it's known that basal cell carcinomas are probably more like melanomas in terms of having an ultraviolet exposure etiology that's more related to sporadic, so I'm trying to get myself on camera, sporadic exposures like this, whereas squamous cell carcinomas are probably more likely to be associated with a steady linear increase. Now, farmers and rural people, in my experience, certainly farmers, are much less likely, I think, to get sunburns than people that live on the coast and have recreational exposures. That doesn't necessarily explain the difference here between head and neck and basal in basal cells and in squamous cells. But I think there is clearly a difference in the exposure these people are having, which explains to a degree the significant difference in distribution. Next slide. So you have to do another click. Sorry, I should have taken all of the build out. Okay, that's actually a basal cell in the back that we took off. So this slide shows the age differences, and we actually did a case control study. So if you'd like to do this, I'm very happy to send the methodology over and assist if I can. Essentially, when we found the cases, we then went back and went, okay, well, let's get a control group of people that were members of this practice. So, and in the same postcodes, and that were allocated in non-melanoma skin cancers one-to-one on a age categorisation. So we basically divided up the cases into 5-year age categories, and then we recruited people in that age category that was the same number as the cases. So we got approximately the same number of cases and controls, and we found that we still had a slight difference in the average age, but the standard deviations are well and truly overlapping. One of the things we also did was we looked at, if you click a few more times please, Zana, we looked at cross-tabulations between farmers and non-farmers, and the data down the bottom, you'll see the one in the middle actually, we in the practices we weren't all that great at recording occupation. We had a lot of people who were retired who get skin cancers obviously, but we aren't recording retired farmer or retired bus driver or retired council worker or something, you know, and that's a bit of a limitation. Nonetheless, we've got a fairly large group, and when we we did found that there was a statistically significant increased risk of non-melanoma skin cancers amongst farmers compared to non-farmers in the same community. So we're not comparing these to Tasmanians, we're comparing these to other Queenslanders living in the same town. So very clearly farming has an increased risk of non-melanoma skin cancer, and it appears in a relatively conservative way to be approximately twice that of people that live in the same community. Next slide. So this was a bit of an out-of-focus melanoma that we found. When I worked in the UK, I had a chance to do a postdoc over there, and the GPs there didn't believe that melanoma actually existed in anything short of level 3. And you know, I find that Australian GPs are very good at finding melanoma in situ, but there's very little data about that. So one of the things we did was we divided up the melanomas we found, and we looked at the number of melanoma in situs compared to the total number. And if you click one more time, a blue circle should come up on the right of the slide as you look at it. These GPs who are, you know, have an interest in skin cancer because they're in Queensland and they're doing some of this, but these are all just the general practices in these towns. We're able to find melanoma in situ more than half the time. So more than half the melanomas that they identified were found in situ, and I'm sure you're all aware that that really opens up the treatment opportunities and also improves the survivability for the patient who's given that diagnosis. So one of the things that we looked at then was that there is some data coming out of dermatologists, coming from the dermatology world, that says, well, actually, you know, it's fine for GPs to look after melanoma in situ because it's actually a different disease. It's not a disease that's necessarily on the spectrum of melanoma. So we tested that by looking to see whether there's any sort of independence, because if it is a different disease, then we'll theoretically have a different distribution. And in fact, it doesn't. And I think that's really just, you know, I think a red herring argument that has been put forward. Interestingly, though, it was very difficult to find any data to say, well, you know, other craft groups in medicine, what sort of rate of in situ lesions are they finding? You know, and there's actually, if you look very carefully in the literature, Memorial Sloan Kettering over in the United States, which is a centre of excellence, have a dermatology department. Within the dermatology department, they have a skin cancer subspecialty department, and in that country, people are able to go and see those people directly. So essentially, it's relatively comparable to a primary care circumstance in that there's not the barrier of having to go through referrals. And for those group, the data was really not any great difference. I think they had of all comers were found in the in situ stage with these super specialists in their super specialist service. So, you know, I was quite encouraged by that these general practitioners, you guys, are actually really good at this in Australia. We did look at the recurrence rate. We've actually got another study going now looking at the longer term recurrence over 5 years, but we looked at 1 year and we found that of all these melanomas there were no local recurrences. So it's not as if these GPs were inappropriately taking out melanomas, although the AJCC, the standards of treatment of melanoma, have just recently changed to the 8th edition, which require us all now to effectively send in any melanoma that you think might be 1 millimetre thicker for sentinel node biopsies, which, you know, I think I've got feelings that that's not necessarily in the best interest of all patients, and I think it still comes down to that this is more about a GP treating a patient than about treating the statistics. And certainly a number of my patients, when I talk to them about sentinel node biopsies and how to get the benefit out of that, they then have to look at going onto a monoclonal antibody protocol, which is the only way that actually is demonstrated to be an improved survival outcome. They're not necessarily keen to go and do all of that stuff, and so I find that you know, probably up to half of my patients, when you give them the full information and consent, they're not necessarily interested in going on and getting further care. They just want it managed here. So We looked at the Breslow thickness. Now, since this was done, Breslow thickness data is now commonly quoted as a millimetre or less, and that's, I think, associated with the new AGCC standards. But, you know, this level of the average Breslow thickness found by GPs being 80% or so, it's actually higher. It's like 85% for the 1 millimetre ones, which means that we're treating, you know, more than 8 out of 10 patients appropriately in a general practice environment. Next slide, please. Right, so this was the original data that we got on the melanomas for farmers, and you'll see my farmer back again here. It was really interesting that we first got this data, and I was convinced, having been taught that farmers have an increased risk of melanoma, that we would get, you know, I carried a bias into this study expecting to find an increased risk of farmers for melanoma. And in fact, when we started to get the data back, I had a very close look at it thinking that it was actually wrong. But as the numbers grew, the confidence intervals narrowed, and we were able to demonstrate that the risk of melanoma for farmers is actually no greater than the other people in their community. And those confidence intervals are steadily coming down as we've increased the sample size a bit further, which was somewhat of a surprise. But, you know, I think it comes back to that, in my experience, I rarely see a farmer who gets sunburned. I see farmers that have a high chronic exposure to ultraviolet, and they have skin like leather that, you know, blunts my scalpel, and you know, it's not uncommon for students to break needles in them, I find. But nonetheless, they're probably not getting those sorts of exposures that do lead to melanoma, which are spikes of ultraviolet exposure that probably compromise immune surveillance as an adult. Next slide, please. So, going back to the epidemiology that we can then surmise from this, you know, we found that students are actually really good at doing this in general practice and really valuable. We found that the mean age was older than population studies with inclusions, and I suspect that's actually because, as it turned out when we presented this, the Q skin data, the survey actually capped people coming into it with at the age of, I think, 67 or 69. And, you know, we found our average age of the cancers was actually greater than the upper limit of who they are accepting in. The other things we found, you know, you might have noticed that the total numbers of basal cells and squamous cells were actually pretty comparable. And initially, again, I thought this was a mistake, because we're all taught that, you know, if you see something scaly and raised or ulcerated on the skin that's been there for a few months, it's probably a BCC, and you're going to be right 2 out of 3 times. Well, in fact, that's not the case, at least where I live. And BCCs were not the most common keratinocytic cancer. Now, when we look back in the literature to see why this was, why were we getting such different data, I suspect it is partly associated with that ultraviolet exposure that farmers get, or people in rural areas get, that's different to people that live on the coast, who are perhaps likely to get recreational exposures. But a lot of the original literature that came out from about the late 80s and 90s, some of it, much of it, excluded intraepidermal carcinomas for some reason. And I asked some of the older researchers about why this was, and it was really just, at the time, it wasn't considered to be a worry, intraepidermal carcinoma. And so there's quite a number of studies that exclude intraepidermal carcinoma. And when you count them in, because they are a squamous cell carcinoma, certainly Medicare consider it so for billing purposes, then squamous cell carcinomas in our series actually became the most common non-melanomatous skin cancer. And that's really relevant, because remember what I said at the very beginning, that about half as many deaths as from melanoma occur from non-melanomatous skin cancer, and virtually all of those are associated with squamous cell carcinomas. So the fact that we're able to find squamous cell carcinomas very early in general practice as intraepidermal carcinomas is really a major public health coup, I think, because we're finding cancer early when you can treat it, and maybe not even have to treat it surgically. You can treat IEC medically. We found there was a different distribution, which we discussed. Squamous cell carcinomas were found early, which I just mentioned, so melanomas. farmers do have a greater risk of non-melanoma, but probably not melanoma compared to the other people in their communities. But above all, I think it said to me that skin cancer is different in rural communities. And it really just fueled my surprise that we're not screening for this. And we're not actually recognised as screening for this, even though very clearly GPs are finding cancers early because they're not looking for them. Next slide, please. So this is where I had to end this one because this was a 10-minute talk originally. So if you could just go to the next slide, I'll briefly cut through some of the discussion. So these are the number of melanomas that we found that are reported back in 2013. I think there's actually more data out that says it's still around the same number. The College of Dermatologists say that we shouldn't be screening, and the Cancer Council also says we shouldn't be screening. I think that's really on the basis of cost effectiveness and on specialist advice. Next slide. There is some data that was generated by Cancer Council Queensland that indicated whole body screening did actually find melanomas earlier when you used the 2 millimetre mark for depth of melanoma. But obviously 2 millimetres, there's an 8-fold increased risk of dying when you go from a 1 millimetre melanoma diagnosis to a 2 millimetre melanoma. So, you know, the clinical relevance of that finding is not all that significant. So if you look at the Americans, they believe that they're finding more melanoma in situ, which is a positive thing, I think. But nonetheless, the US Preventive Task Force, which is a group that basically says what you will screen for and what you won't screen for, says that there's insufficient information to determine that it is actually on balance better to be screening, and therefore they don't support screening. Now, I think if there's insufficient information, it behoves us to gather that information, considering we're talking about cancers that kill a lot of people and certainly consume a lot of the health dollar. Next slide, please. So, as I mentioned, I looked at what we should expect from the percentage of melanoma in situ, considering that, you know, GPs are finding them at approximately 50% of the melanomas that they're finding are in situ. In the States, it's actually lower than that. In Denmark, it's much lower than that, which I think reflects a medical workforce that is either inclined or not inclined to look for this. So I think Australian GPs, certainly when I studied in Austria, in skin cancer, the Australian GPs that went over for the course, and some of you may well have gone on that course at Graz, the Australian GPs were just streets ahead of the dermatologists in Europe in terms of their familiarity with skin cancers, all forms of skin cancers, and their ability to manage them. Similarly, in the Netherlands, the rate of MIS is quite low. Next slide. And here's the story about Memorial Sloan Kettering, which, you know, I was really chuffed to see that. And when I went back to the GPs who showed good faith in allowing us to bring students into their practice, well, they had students in their practice already, but to allow the students to do this research, they were really quite chuffed as well that they were as good as these subspecialists. And, you know, I think this probably reflects the quality of general practice, and not only the quality of the practitioners, but also the model, I think, helps us to have a relationship with patients, and that those patients are then inclined to come in early with their skin cancers, and that's a major strength for us. Next slide, please. So then the story about the ratio of BCCs to SCCs. You know, I had taught up until about 2 years ago when we got this data starting to trickle out that you know, if you see something scaly and raised that's been there a while, and call it a BCC because I was only going to be right. I've changed my teaching, but that's generally what was around the traps. It's interesting to look at the international data compared to the Australian data, where there is a trend in Australia to a higher proportion of squamous cell carcinomas. So you see in the United Kingdom, it's 3.5 BCCs to every 1 SCC. But even when you get down to the Australian studies, it's now getting closer to 2 to 1. Now, I wonder whether this is related to the nature of ultraviolet exposure that's seen in Australia, that is more favoured towards those chronic exposures as opposed to the intermittent exposures that more push towards a basal cell predominance. But I would point out that these studies specifically excluded intraepidermal carcinoma. And in fact, I couldn't find any research in the literature, in the scientific literature, that looked at what proportion of IEC should we be seeing. Next slide. So I think we found a lot of new information in this, and I think that the model is very suited to other regions looking at what sort of skin cancer epidemiology they're getting and how that would change the way they would address their skin cancer approaches. Look, at the very least, I think if you do this and identify how good your general practices are, then I think it's a wonderful endorsement for the community that you're in to say, well, this is actually a great place to come to get your skin cancer identified and managed. So this is actually my last slide, I think. Since we've done this, we have done some more data as the powers come up on the number of melanomas we have, and we've actually managed to move the findings of melanoma thickness being found at scheduled skin checks to demonstrate that patients that present and have their melanoma diagnosed at a scheduled skin check, as opposed to those patients that come and have their melanoma incidentally diagnosed or at an opportunity screening, the ones that are there for the scheduled screening are statistically significantly more likely to have their melanoma less than 1 millimetre. Now, that's the first time that's ever been demonstrated, and we're writing that up to put out to literature shortly. But it's a further endorsement of the value of screening and of the model of care that general practitioners deliver and the quality of care that they're providing. So thank you very much for listening, and I hope that has, at the very least, encouraged you to continue working in this field.
Thanks, Scott. So if anyone has any questions, feel free to leave them in the comment box. We've got a few minutes. We've got actually 10 minutes or so. So this is more than enough time for us to go through any questions that anyone has. So you can just write them down in the comment box. Also, while we're waiting for questions, if you could please complete a short evaluation on the webinar. I've also left the link in the comment section as well. So if you could just quickly complete that, that'd be really wonderful. And also, if you'd like to keep up to date with other GP-related events and webinars coming up, make sure to follow us as well on our webpage.
Do you want to just read them out if they come up at all? Maybe I'll just stun everyone.
Yeah, I can just, I'm just waiting for questions, and then I can just read them out as opposed to sending them through to you. So we'll just wait a few more minutes maybe. So there's a question/comment that's come in. A screening program needs more than evidence that you find /clear histological disease. I'm not sure whether that's a question or...
There's actually 9 criteria put forward by the WHO that Australia's adopted for whether or not you should do a screening program. You're right, it needs to demonstrate more than just that we find cancers at an earlier stage. The further criteria are that if you intervene on those cancers that are found at an earlier stage, that it actually makes a bit of difference to mortality and morbidity, which is why we're doing further research on if these things are managed in general practice at an earlier stage, does it actually change the risk of recurrence? And the preliminary findings are that it does. We're finding that the recurrence rate in general practice surgery for cancers that found earlier is certainly very good, and certainly the practices that we're doing it at. My routine is to quote that if I take something off a non-melanoma skin cancer, then you've got a 5 or 10% chance of it coming back. In actual fact, we're finding that the rates for the GPs on the Darling Downs is probably less than 1%. So you're right, there are more things to demonstrate. There's also the economic argument of how much does it cost to do this screening versus how much have we saved. I think this is probably low-hanging fruit because the cost of non-melanoma skin cancer care in Australia is so very high. It's estimated to be over $120 million a year. So there's good opportunity for the economic argument to be demonstrably better. But before we get to that, we really have to have more epi data to be able to feed into the economic models. So yes, good point.
Yeah. One more question is, based on your research, does if in doubt, cut them out apply?
Oh, yeah, absolutely. I think we approach teaching our medical students and registrars from the point of view that, we teach all of them dermoscopy, which we know increases sensitivity to identifying melanoma and pigmented basal cell carcinomas. And we teach them that if in doubt, cut it out, because essentially you don't want to let one of these walk out the door. I think that the corollary to if in doubt, cut it out is that you probably should be doing your own clinical auditing to see what sort of benign malignant ratio you're getting. And, we know that Australian GPs are actually pretty good at this, probably still have a benign malignant ratio that's, over 1 to 20. But nonetheless, you should be looking and you should be learning from the histology that you do. But I think if your benign malignant ratio gets too small, you're probably starting to compromise the if in doubt, cut it out, and attempting to improve your specificity. And that commonly in epidemiology is at the expense of sensitivity. So my advice would be to, if in doubt, cut it out, because that bumps your sensitivity up.
Another question from Gul is, can we comfortably exclude skin cancer, especially melanoma, after doing a routine whole body check? I mean, from medical legal point of view, sometimes patients ask you, doctor, are you 100% sure I don't have skin cancer? What should you say?
Well, I often say to them also, I can't be 100% sure you haven't got bowel cancer either, but what we can do is keep looking. If somebody is a high risk, so they've got a primary relative, they've previously had a melanoma, they've got a high risk occupation, they've had, certain, phenomenal skin cancers, they've had chemotherapy, I'll ask them to come back more often. I've never had any Medicare audit associated with reviewing patients that are demonstrably high risk, every 6 months. And if they're particularly concerned about a lesion, then I will image it, and I'll use comparative dermoscopy, so that I'll use serial imaging. And I find that with patients, if you engage them in that diagnosis in that screening process, so I'll often get them to image it on their phone as well. And then we come back and we look at those images, and patients get that things don't change, or they get that they do change. One of the best ways to get consent to excise a lesion is to show them before and after image, 3 months apart for comparative dermoscopy, and they all get that cancer changes. And the other side of that is that they get that it doesn't. So I think we've got to recognise that people are concerned about this, but not ever get drawn into the, I'm giving you a guarantee you don't have melanoma. Well, you may not have melanoma today, but you might have it tomorrow. The reality is that melanomas probably develop over decades. And so the current thinking is that you probably got your melanomas before the age of 20. And then your adult exposure modulates the expression of that cancer. So, I would never say you've definitely not got a melanoma, but I would certainly explore their reasons for being concerned about it. And very often you find that it's because they've had a friend who's just died of a melanoma, or they've had a relative who has been diagnosed with melanoma. And quite reasonably, they're worried about it. And, as general practitioners, we don't just treat the disease, we treat the patient. And that's a great example of it, I think.
Thanks. A question from Jane is, what are the indications for referring to a dermatologist for a skin check rather than doing it in the GP clinic?
Look, I think if you're not comfortable in doing it, then refer. My advice would be to refer to one of your colleagues so that the patient can get good access. And in our practice, there's two of us that do a lot of skin cancer stuff, and there's a number of people that will do it if they have to, and then there's one guy who absolutely doesn't want to touch it with a barge pole. He's too worried about it. And we do internal referrals. You can do that. To be honest, I can't remember the last time I referred to a dermatologist. I will refer to a plastics or a gen surge if I'm not comfortable with managing it. I think the dermatologists don't have some of the benefits we have. They're not seeing as many cases. They're not seeing the cases early. And they don't have the access to the people. And so, it's not easy for dermatology. If you actually look at their training program, it often doesn't include a great deal of skin cancer. So I don't think that they necessarily bring a lot of benefit unless they've got a specific interest in the area. And in the area I live in, the dermatologists don't. They're also very expensive, and patients don't appreciate that. And their waiting times are high. So if you've actually got somebody who is concerned about a skin cancer or a lesion, then derm's not where I'd send them. I would send them to one of the colleagues first that has an interest.
Thanks. Another question from Jane is, are there many bulk billing skin check clinics in Australia?
Yeah. Well, I don't know much about all of the rest of the places. I think that in regional areas, certainly in Toowoomba, it's hard to find that. And I think you need to be careful with, there are some amazing clinicians in some skin cancer, essentially specialist clinics, who are GPs who've specialised in the old-fashioned way of specialisation, who are extraordinarily good, and I don't know that many of them bulk bill. We incidentally bulk bill where I work because of the funding model of the practice. It's a community-owned co-op, but I don't see many of my colleagues who do bulk bill, and I think that is a bit of a barrier. Personally, I like being able to bulk bill, but then I accept that I don't earn as much money as a result of that. But it's a nice feeling that when somebody does have a cancer, that you can say, well, look, it's not going to cost you anything to take it off. You probably need to look around your own area and decide where your internal referrals or your practice referrals will go for different ways you probably do for allied health and other medical specialties.
Thanks, Scott. One more question. Oh, sorry. So one more question is, what's your recommendation for follow-up skin checks once you diagnose a melanoma or non-melanoma skin cancer?
Yes, good question. One of the studies we have our students doing now is comparing the nature of follow-ups that GPs do. If you actually look at the therapeutic guidelines, there is a set protocol for both non-melanomatous and melanomatous skin cancer. I tend to be a little more assiduous than that. We actually put forward a grant application to the college to ask about whether we can look at what GPs think is an appropriate one to see their compliance, because I suspect it's not very good. The college didn't feel that was actually important enough to fund. But my personal approach is that if somebody has one melanoma, that is the most important risk factor for having a second melanoma, and I mean a second melanoma as opposed to a recurrence of the first melanoma, because we know that the ultraviolet lights and their personal genetics and their personal habits are enough that it's caused one melanoma, and there's the rest of the skin, so that's just as much high risk. So I actually see them quarterly for the first year, looking very closely at their recurrence locally, as well as whether they're going to develop that other melanoma elsewhere. And we know that about 20% of patients will actually turn up with another skin cancer elsewhere after their original diagnosis when you do check them again. Thereafter, I say to them, look, I would be very happy to see you half yearly. I think the NHMRC guidelines suggest yearly after that if you now have a major risk factor. For non-melanoma skin cancer, I use the same protocol. It depends on the nature of management that I've used, but in that first 3 months, I may see them a lot more often, particularly if you're taking off a really large basal cell or squamous cell, or you've done a deep non-melanoma that hasn't necessarily gone off somewhere. And I find that managing their wound closely is very important. So in my practice, we actually see them at day 3 and then day 7, day 10 and day 14. If I've done a keystone flap, we'll keep seeing them weekly until I take the stitches out, usually at about day 28. And then they fit into the follow-up for recurrence.
Thank you, Scott. I think that will be all for questions tonight. So I'd like to say thank you, everyone, for joining us tonight, and I'd also like to say thank you to Scott for taking some time out from his very busy schedule to share some really insightful findings from his presentation and his research. We've just had a question come in. Scott, are you okay to take one more question?
Sure.
Yeah. This person is asking about recommendations for skin checks with people with a strong family history of melanoma.
Yeah, so NHMRC would say that you should do them second yearly, but in somebody that has a strong family history, and by strong family history I would say that they have a primary relative with a melanoma or they have 2 secondary relatives with melanomas, then I would normally put them onto yearly. You do find that if somebody else in the family has had a melanoma that's near them, they tend to be quite concerned, and they may initially want to see you more often, but then they'll settle into a regular habit. Another thing I can say about that sort of screening periodicity, when you do it, is to bring the kids in. Not because I'm particularly going to be looking for a melanoma in an under 16, which is, rare as rocking horse shit. But it's very important, I think, for that family and those children in that family to understand that the parents value screening for skin cancer, that it's in the family, it's something that potentially is in their genetics, and those children need to be indoctrinated early to understand that it's nothing to be afraid of to come and see the doctor regularly to get their screening. And I think that then sets you up for a whole bunch of other general practice public health. So once you start to talk to those patients on a regular basis, that gives you the opportunity to start doing their blood pressure and to start doing the regular screening when they get to the right age for other cancers, such particularly bowel cancer and breast cancer, and talking to them about diabetes risk and weight and smoking and so there's a lot of opportunity, I think, when you have that initial entry point to general practice screening to broaden out your public health approach.
Thank you. So that's going to be all for tonight. Thank you everyone again for joining us tonight and sending through your questions. Again, thank you so much to Scott for joining us tonight and presenting on a really great research that his team has done. So that will be all for tonight. Again, thank you everyone, and if you could please complete the evaluation form, that would be wonderful, and we hope to see you at the next Cancer Council GP Education event. Thank you and good night.